Hello everybody and welcome to Advancing Health and Inclusion. My name is Beth Clark and I'm the coordinator of the Public Scholars Initiative, the organizer of this event. And thank you so much for being here, especially given that it's, I think, 30 degrees outside, really sunny, and this place is quite, not necessarily close to UBC, people coming from UBC, thanks for that. And hopefully it's going to be worth it. I'd like to begin with a territorial acknowledgement. We're here at the ancestral, traditional, and unceded Aboriginal territories of the Musqueam, Squamish, and the Tsleil-Waututh peoples, and we're always grateful for that. Another thing to be acknowledged is that today's Star Wars Day. How many people knew this? May the 4th be with you guys. So I was going to wear my Chewbacca costume, but and I was warned by my colleagues that I need to speak actual words. And also it's 30 degrees, so. So what to expect today? We have a great lineup of speakers of 8 PhD students who will be talking about the outstanding research which is publicly engaged and advancing health and inclusion, as the title suggests. Also, we have a tremendous guest speaker, Colin Van Ushelen, who will be introduced by Susan in a minute, and we're lucky to have him as well. So a word about PhDs Go Public. This is the 5th series of our, this is the 5th event of our talk series, PhDs Go Public. And the idea behind PhDs Go Public is that PhDs should be out there in public, giving public talks in a way that is understandable by the public. This is why we've been doing this, I think, in the last 2 years now. And this year's series had 5 talks. One of them was on education, and then environment, social justice, and so on. And this is the last one of the year, and we're particularly grateful to be with you for that. A few notes, film and photo. So the event is being filmed and photographed. If you have any issues with that, please talk to our photographer Melinda and videographer Chris at the back. And the bathrooms are right outside over there. And also, please help yourselves to coffee, tea, and other snacks that we have for you. You can take the discussion to Twitter using the hashtag UBCPSI, which you may find in the event programs on your desks. And also in the event programs, you may notice that for some of the student presenters, we were able to find their handles, Twitters. So if you want to refer to a particular person, then you can use those. The Public Scholars Initiative was born 2 years ago at the Graduate and Postdoctoral Studies at UBC, and I consider myself extremely privileged to have coordinated it in the last 2 years to be a part of the team. And Susan Porter, being Susan Porter, is, I think, the #1 person responsible for this idea, Public Scholars Initiative. And the whole idea of the PSI is to reimagine doctoral education in ways that make public engagement in a more meaningful way, and also while preparing students for broader career perspectives. So to talk more about the program and also introduce our guest speaker, I'd like to invite Susan Porter to the stage.
Thanks very much, Efe, and it just occurred to me that this is Efe's last PhD Go Public, so we're going to miss you, Efe, and particular thanks for everything you've done over the last 2 years. He's really been the heart of PSI as it's evolved over the last couple of years, so very grateful. I think probably many, if not most of you, know something a little bit about PSI, but for those who don't, this is an initiative that has been percolating for many years. And there's several reasons for it. One is that our graduates, the PhD back in the 19th century was primarily to regenerate the professoriate, and that was an important thing at the time. Right now, about 30% of our students actually become professors after PhD, and the remaining do all kinds of fascinating things in society, in the private sector, in NGOs, in the public sector, and doing all kinds of, making extremely important contributions to our society. And so we are among many people who are asking, is the PhD as it currently exists, is it truly the best way to develop all the talents and all the capabilities that they will need as they go out into the world? And so the PSI is an attempt to encourage and support a little bit broader focus for PhD students to enable them to do the different forms of scholarship that they will actually be engaged in, both inside the academy and outside. It's not exclusively outside by any means. We also are, and this is, I think, a growing concern for universities, is to be as relevant as we possibly can to be for society, to be engaged with society, to be collaborators with those in society and inside the academy to better society, to advance the public good. And so this is part of that as well. We know that PhD students have tremendous abilities and creativity and energy, and we're so delighted that we can support what you guys are doing. It's just wonderful for us. So that was the origin of the PSI. Part of the program that Effie and we have developed involves public speaking, which falls from the concept of public scholar. And this is the last one of this year, and we're delighted to hear from you folks in a very general way what you're doing and what scholarship you're bringing to society and what you're learning and what you're doing. Okay, so we were very fortunate today to have a public scholar, an acting, professing public scholar among us, and that is Colin Van Buchelen. And I'll just read his bio here that came on his website. So he has a PhD from the University of Illinois and is a consultant in community psychology in Vancouver. He has over 25 years of first-hand experience in creating community and collective homes, and he founded Vancouver's Collective House Network in 2007. His workshop, The Heart of Belonging, has introduced hundreds of people to the concept of creating community in their lives. His research has examined the connection between our sense of community and empowerment in community settings. Colin holds a doctorate in clinical and community psychology. So we're really, your topic sounds absolutely fascinating and absolutely important, and we're really looking forward to hearing from you. Thank you. Yes. Okay, got it. Yeah, thank you. And will that mic be okay?
Yeah.
Once upon a time, a kindly old man was traveling through the mountains. He came upon a village, and as he entered the village, the villagers, seeing him, closed their doors and closed their windows and shied away from him in fear.
The stranger smiled and asked, "Why are you all so frightened? I'm a simple traveler, looking for a soft place to stay for the night and a warm place for a meal."
There's not a bite to eat in the whole province, he was told. We are weak and our children are starving. Better keep moving on. Oh, I have everything I need, he said. In fact, I was thinking of making some stone soup to share with all of you. He pulled an iron cauldron from his cloak, filled it with water, and began to build a fire under it.
Then, with great ceremony, he drew an ordinary-looking stone from a silken bag and dropped it into the water.
By now, hearing the rumor of food, most of the villagers had come out of their homes or watched from their windows. As the stranger sniffed the broth and licked his lips in anticipation, hunger began to overcome their fear.
Ah, the stranger said to himself rather loudly, I do like a tasty stone soup. Of course, stone soup with cabbage, that's hard to beat.
Soon the villager approached hesitantly, holding a small cabbage he'd retrieved from its hiding place and added it to the pot.
The stranger sniffed the soup and smiled. Lovely, he said, but wouldn't it be great if we could add a little bit of meat?
The village butcher managed to find some salt beef, and so it went through potatoes, onions, carrots, mushrooms, and so on, until there was indeed a delicious meal for everyone in the village to share.
The village elder offered the stranger a great deal of money for the magic stone, but he refused to sell it and traveled on the next day.
As he left, the stranger came upon a group of village children standing near the road. He gave the silken bag containing the stone to the youngest child and whispered to the group that it was not the stone, but the villagers that had performed the magic.
Round of applause for our readers. Thank you. So let's think about this story for a moment. You have this gentleman coming into the village. People are afraid of him. And he proceeds to sort of open the door both for himself and for the villagers alike in creating this feast. And I have a question for you. Reflecting on this story, what is the magic that he uses to make this happen? What does he do to get people engaged? Anyone?
He exposed the possibility of what it could be like.
He exposed the possibility of what?
Of what it could be like.
Of what it could be like. That's true. He does kind of enable that to happen. And what else does he do? How does he draw people out?
He involves them.
He involves them in the process. That's right. And how does he do it? How does he involve these people who have run away from him actually when he first came? He initiates? Is that what you said? Yes, he does. He totally initiates. And how does he do that initiation? What's he doing?
Communication.
Say again?
Communication.
Communication? And his first communication is essentially to no one in particular, right? He's like, oh, I was about to make a great stone soup for myself, is what he says.
He helps them identify what they have to offer, what they can contribute.
Yeah, he helps him identify what they have to offer. And what is he told when he comes into the village? He's told, hey, we have nothing to share. Our kids are hungry. We're starving here, right? But yet he does help identify what that is. What else is he doing? Who takes the first step? Who takes the first step?
The cabbage?
But yeah, thinking back, what's the first ingredient that goes into the pot? The stone. He initiates that, right? And who initiates having the pot, the cauldron?
He does.
He does. He just so happened to have an iron cauldron under his cloak. A handy thing when you're entering a village where people are afraid of you. So is there anything else in the story that you can think of that helped make these things come together?
He lit the fire.
He lit the fire. Absolutely. He did that to get things going. And what else does he do? Anything else?
When he leaves the stone and, I guess, the responsibility to the children.
That's right. He hands over sort of the magic, so to speak, to the kids. And then he says, it's really not the stone that was the magic. It was the village. It's your community. Thank you. Any last observations? Thank you. So the reason I'm beginning my talk today with this story is several reasons. And one of them is to invite you into thinking about the topic of engagement and inclusion in a kind of, sort of direct way as regards this story. Because in many ways, when you or I go out into our lives or into the communities within which we work, we might be confronted with a similar kind of situation. We have an idea and there's no apparent interest in what we have on the go. And it becomes a challenge for us to consider how will we engage the people in the communities that we care about. Importantly, in the Stone Soup story, this traveler does something which addresses a deep need of the village, and that is their hunger. And even though maybe he doesn't bring a food item to make this stone soup, he does bring the elements together of what it takes to open up a space and to open up a method for people to share with one another, and thereby sort of create not only this abundance, but also a momentary sense of community within this village, and a moment that includes everyone and himself in the circle. This story is also the way I begin my Heart of Belonging workshop. Now, this workshop I began about 5 years ago as an idea. I was working with an undergrad research assistant at the time, and she was interested in going on to grad school in psychology, and my degree is in clinical and community psychology. And one of the areas of interest that I've long been interested in is our sense of community, that is the experience of connection we have with others within the communities to which we all belong. And our neighborhoods tend to be one such community, but not the only one. Many of us are in social organizations or belong to a community that might be defined by identity, such as myself, as someone who's lost eyesight, and I now work with a guide dog. I am a member of that community of blind guide dog users. And I have a feeling of connection and experience of belonging within that circle. And this interest of mine, I thought about, well, should I write a paper for publication or do some empirical research or, measure it or whatnot? And I realized that what I really wanted to do is take what is known within academia, within the scholarly literature on this phenomena, and make it accessible and make it public and make it available for other people to learn from, and in the process also to examine their own experiences of connection within Vancouver. And we've been hearing a lot over the past 5 years or so about how disconnected Vancouverites are and how belonging or social isolation is such a serious issue. And the workshop that I do kind of does the opposite to that. It says, let's take a look at our lives and areas within which we do feel connected. Or let's take a look at those moments in our lives that we've all had within which we feel profoundly connected with one another. And then I'd like to unpack that. I'd like to help people walk through that to say, what's going on there? Where did that occur? What setting was it? Who were you with? What was the community? And what contributed to that feeling of connection? And so within the constraints of the workshop, each individual then sort of unpacks their own experiential knowledge about this topic. And it sort of honors that people have wisdom that comes from themselves. And in so doing, it includes participants in sort of the collaborative, participatory thinking and examination of the phenomena of interest, and in this case, the sense of community. And then I bring in a little bit of what's known for the literature. I bring in a little bit what's known from my own professional experience and my own lived experience. And then we have a lot of activities and interactions and individual exercises that unfold throughout the workshop for people really to kind of take a look at that. Okay, what is this experience like? What can I do as an individual to enhance the likelihood I'll feel connected? And how can I sustain that experience over time, not just for myself as an individual, but also for other people who belong to the community that the participants belong to, whether it be their neighborhood, their church, whatever. And in so doing, it's sort of a public, I guess, a publicly accessible exploration of a topic which gets quite technical in the scholarly literature within my discipline in psychology, and is a way that I take what I learned in graduate school and what I've done with my PhD and sort of make it open to the community. Within community psychology, this is an important idea, and in particular when it comes to research and intervention and the kind of activities we do to be of service to other people, to do so in a way which really honors and respects the wisdom and experience and knowledge of the people who we work with and who we participate with and who we invite into our research and our initiatives. And this, in the words or in the terms we use in community psychology, this is about having an empowerment social agenda when it comes to how we handle ourselves as professionals. And so what I want to do for each of you who are here embarking on or in the midst of a PhD and looking ahead to what you're going to be doing, you have tremendous opportunity to define your topic or sort of shape the way you approach your topic, which includes other people, in quite a meaningful way. And if you think back to the story about stone soup, it's the traveler who comes up with this very clever and very elegant engagement strategy. So when he comes into the village, he makes it possible, even desirable, for people to make a contribution to his initiative. And he's not saying, hey, I need somebody, you live in the old rundown house. We need people like you to participate. And you look like you don't have quite enough vegetables in your life. We need you to participate. He's not doing that at all. He's not sort of defining his target group within which he wants to intervene. Rather, he's making possible something of value and making it readily accessible for everyone to share in. And that's an idea that I would invite you to consider with your own work and your own research, to think of it as an asset, as a resource that you want to make interesting enough so that people willingly want to come to you and share in it and share in its value, and that you also honor their experience, their wisdom, and their contribution to making that resource, that asset, that knowledge, that initiative that you're doing something that's tremendously applicable to people's real lives in the real world. And in so doing, you can sort of help identify and build on strengths in the lives of people that you're going to work with. And I find that that's a much more engaging way, and they find it much more fulfilling to work with you when you come with something that really focuses on people's strengths, as something that focuses more on their weakness, their deficit, their pathologies. And so in sum, my discipline, psychology, I actually also did a little bit of work in medical anthropology, and I traveled overseas. And having had that experience to kind of get me to think about culture and the differences in different cultures and how they approach the topic of health and mental health, and how culturally anchored much of what we do really is, I think it just humbled me a little bit to be a little bit more open to working with what people have as a guide for me into their worlds and into a way that I can think of for myself how I can be most useful. And I would invite you to do the same. Thank you.
We have a few minutes for questions.
When can I go to one of your workshops?
Well, thank you. If you want me to set one up, I'd be happy to do that with you. I offer the workshops now with the support of whatever organization that wants to bring me in. And currently it's the Vancouver Foundation, who I invited to attend a workshop. They have something called the Neighborhood Small Grants Program, and they got very interested in the work, and so they support me to do it every spring. And I can let you know next time I have one booked, but if you want to help set one up, that would be great. You could all come. It's a lot of fun.
What got you interested in this field? I realize I see your PhDs in clinical, and I've never actually heard of community psychology, but that's me. What drew you to this concept of enhancing community?
You know, it's been with me a long time. I think I've often liked living collaboratively and cooperatively with folks. I did that before I went overseas, but I think it really consolidated or gelled inside myself when I lived in Indonesia, and I was in a remote village in the island of Sulawesi. And the village, the poverty is profound, but the collaborative, collective, community nature of the village was so inspiring. And to see that at work and to kind of feel like I was part of it during the time that I lived there really sort of clarified for me my interest in that topic. And so when I was looking at graduate schools and I chose a program that had a community psychology emphasis. And community psychology is really, it's like a public health approach to mental health. And it's a discipline within which we recognize that people's psychological sense of community is hugely important in their overall well-being. And it's the disconnection, the isolation, the disenfranchisement, which is quite disempowering and quite unhealthy. Yeah.
Being mindful of time, I'm afraid we'll have to continue, but please join me in thanking Colin.
Thank you.
So before we begin, I'd like to thank Sunny Hill, first of all, for opening their doors, and we're very happy to be here. And also the Aarthi Gobinath Learning Center at UBC, who's sponsoring the recording of this event, which will be available on their webcast. So a word on the structure before we begin. So we'll have 4 PhD students speak first. They have each roughly 5 minutes to talk about their research, which is a huge task. You spend years on the research and then you're given 5 minutes. It's kind of brutal, but that's the point. And then after the first 4 presentations, we'll do a short Q&A. We'll take a break for about 5 minutes for more coffee and cookies, and then we'll continue with 4 more presentations and a Q&A, and then we'll call it a day. Sounds good? So our first speaker's research examines how relationships between human beings support or hinder evidence uptake in healthcare. Her collaborators include rehabilitation centers, research institutes, government, and provincial and Canadian health networks. By targeting the social influences that drive evidence use by health professionals, administrators, and policymakers, our speaker aims to improve patients' timely access to healthcare innovations. Please welcome Stephanie Glegg from Rehabilitation Sciences.
What do we need to do?
apparently fell asleep, so we're waiting for it to wake up.
I'll wake you up. Okay. My name is Stephanie Glegg, and I'm studying how networks of people in our healthcare system impact the use of research in healthcare decision-making. And I'd like to acknowledge the support of my funders and affiliations, including the Public Scholars Initiative at the University of British Columbia. The biggest problem in healthcare today is that when new, high-quality research demonstrates that a treatment is effective, it takes 10 to 20 years for it to be adopted widely by healthcare providers. This means that many children miss out on the treatments that they need because they time out of the system before our health services can catch up. Another pressing example is the overdose crisis in BC. Over 900 people died last year, despite research telling us how to prevent those deaths. We don't have 10 to 20 years to affect policy change. This is a public health emergency, and people are dying every day. We need to find better ways to work together to save lives. So I'm involved in a research project where we're interviewing patients and families, community groups, frontline workers, health leaders, researchers, law enforcement, policymakers, and the media to learn more about how and when stakeholders interact about drug policy change, so that we can make it more efficient. Every one of us deserves access to the safest, most effective healthcare treatments available, but because of this gap in what we know and what we do, up to 40% of patients fail to receive the best available care, and up to 20% receive ineffective or even harmful treatments. We can do better. We also invest millions of public tax dollars in health research every year. Much of this is wasted money if the research doesn't get taken up by the people who have the capacity to act on it. Suboptimal collaboration across research and healthcare sectors is one of the factors that slows research uptake. Most research that studies how best to move research into action focuses on raising awareness of the research, packaging it in different ways, or training healthcare providers in how to administer the treatments. These approaches can improve knowledge and skills, but they aren't very effective at changing behaviors. They also ignore the role that our social worlds play in changing our behaviors. My PhD research looks at how to build relationships among healthcare stakeholders, including researchers, healthcare providers, leaders, and policymakers, to improve research use. Because of the broad range of stakeholders involved, I'll be tailoring my findings into key messages and formats that will address each of their information needs. My dissertation will include a policy brief for government, an executive summary for health leaders, published articles for researchers, and infographics for other stakeholder groups. I'll be using an approach called social network analysis. This approach is concerned with the patterns of connections among people and the nature of those connections. I'm not talking about social media here. I'll be studying face-to-face interactions within groups of people in our healthcare system. We can use social network analysis to describe these networks in detail and to represent them visually. Then we can explain why the patterns we see are happening and understand how they influence an outcome, such as research use. For example, we might have well-connected subgroups that don't interact, hierarchical structures, or even isolated individuals that don't have access to information or resources. But what do we do when we find gaps in the network that hinder research use? We can still use support strategies that raise an awareness of the research, that improve knowledge, skills, or attitudes about the research and how to apply it, that facilitate research use, or that reinforce these behaviors. We just go about it in a different way. So we can identify champions within a subgroup to effect change there. We can target an entire subgroup that needs support, We can foster targeted interactions to promote collaboration and knowledge sharing, or we can add or remove connections to improve the processes involved in research use. My research will study the networks of researchers, healthcare providers, leaders, and support personnel at 2 pediatric rehabilitation centers. I'll use an online survey to identify gaps or weaknesses in each center's network that we can target to improve the awareness and uptake of research. Then I'll conduct interviews to learn from different people in the networks about what works, what hinders research use, and what supports are still needed. Then I'll test the effectiveness of a network intervention designed to target these gaps. It might involve identifying key people who can connect subgroups, or finding new paths to enable network members better access to information or resources that will help them to integrate evidence. And all this is so that our children can benefit from the safest, most effective health innovations available. Thank you.
Thank you, Stephanie. Our next speaker is a passionate advocate, teacher, and dedicated community member. She brings these qualities to bear in the collaborative project titled Being Blind. The Being Blind team is working to expose misperceptions resulting in marginalization and create an engaging campaign challenging what we think it means to be blind. To tell this story, please welcome Laura Bulk from Rehabilitation Sciences.
So this first slide features a photograph of 2 white canes sitting on the ground and someone's feet standing beside them. And it is titled Belonging. It was titled something else too, but that got cut off. And also has my Twitter handle at LYBOT, so you can tweet about it. So we all need to belong. It's a basic human need. And we find a sense of belonging in various places doing various things. So we find a sense of belonging in churches, in schools, in labor unions. So this slide features 3 pictures. One is of a school building, another of a church filled with colorful people, and another of a crowd of protesters. So these are places where we seek belonging, but unfortunately, not everyone experiences the same sense of belonging in these places or others. One person has described that there is a gulf between her experience as a blind person and the experiences of sighted people. She says that this is at the heart of her experience of exclusion and otherness. So I'm asking, how can we reduce our collective and our personal experiences of alienation? Being Blind explores the experiences of blind and partially blind individuals, and specifically looks at belonging and how these experiences of belonging impact our participation. And we will also harness the power of stories and also the collective creativity and wisdom of the community to help impact change. We hope that through increasing understanding that we will increase experiences of belonging. This slide features 2 pictures which have abstract humans on them. The first one is of one person at the top and an arrow leading down to a crowd of other people. The other image, in contrast, is a crowd of individuals with arrows pointing from one to the other in all directions. So another aspect of being blind is that we are challenging the way that disability research has traditionally been done. I hope that being part of this process is going to be an empowering experience for everyone involved. A lot of research has been done on disabled people, and this has been seen as oppressive, and a lot of people now mistrust research. In contrast to a traditional approach wherein a researcher has a research question, comes into a community, collects data, goes off and analyzes it, and then does something with it. The Being Blind project, for this I'm going to be inviting other members of the blind community to be a part of a research team, and we'll decide together what are the most important questions in this realm, and how do we want to approach it, and what do we want to do with what we find. As a co-researcher who has the privilege of an education and of knowledge, I'm going to be putting my skills and my resources and my knowledge at the disposal of the research team. This slide features a picture of Artem, who's a young man, and he is leaning toward, nose to his tablet, reading a web page. In collaboration with an international social justice advocate and photojournalist, Marilyn Smith, we are working together to build a platform for an exploration of being blind in a variety of economic, geographic, political, and social contexts. And we are also going to use this platform to challenge misconceptions of those experiences. We aim to prompt action and advocacy that will improve quality of life for blind people and also public understanding about blindness. The narratives of co-researchers and participants, as well as the photojournalistic work of Marilyn, will form the basis of this multimedia platform. Contributors will include blind and partially blind people and people in our social networks who can share stories and experiences, as well as experts, which include people who are blind, who can share expertise around access to technology and around how we can change the social and economic situation of blind people, and around personal skills and so on. It will also include contributors from the public who can ask questions and interact. This one single portal for storytelling and reporting on academic and technological advances will build a bridge, create a link between evidence-based research and real life. This site will also profile people from 8 countries around the world, probing the experience of blindness in various contexts, exploring how we defy stereotypes, and exposing the stigmas that get in our way. In parallel, experts and community members will be contributing blogs that will facilitate knowledge exchange, resource sharing, and hopefully generate dialogue. So you better go to the website once we have it. Being blind aims to help people adopt a new pair of lenses, so to speak, one that's tinted by a greater understanding of what it means to be blind, which is why this slide features a pair of spectacles. So being blind is going to benefit blind people by providing a space to share our stories and challenge the stigmas that lead to our exclusion. It will benefit experts by offering journalistic coverage of academic research and technical advances. It will impact policymakers by providing content that can inform equitable approaches. And guess what? It'll impact you because you'll go to the website and you will interact and you will build your understanding and your awareness of what it means to be blind. Thank you very much. And if you have questions, I'll answer them. But not now.
Not now, yes. That was my point. So we heard from 2 Rehabilitation Sciences students. Now it's time to hear from an engineer. Our next speaker is interested in applying his science and engineering knowledge to help people with disabilities. His research allows him to work directly with stroke survivors and therapists to develop new technological solutions to current rehabilitation issues. And also, I think it's safe to say that you'll be finishing quite soon.
Yeah.
So please welcome Bulmaro Valdes from Biomedical Engineering.
Thank you, Efe. So today I'm going to be talking about a project that my PhD project in which I looked into how to reduce unwanted movements in stroke survivors with the use of technology. So today I'm going to be talking about stroke. So first of all, what is a stroke? So a stroke occurs when one of the blood vessels leading to the brain gets blocked or ruptures, and because of the lack of blood supply, some of the brain functions are affected. And what happens is that with a lot of people after a stroke, they suffer from difficulty moving their arms or their legs. In my project, what I did is I focused on the arm because a lot of people, even when they go to therapy after a stroke, they don't fully recover. So that got me started thinking about using other ways of trying to get these people better, and in this case, trying to use technology to do that. So I had 3 objectives in my project. The first one was to promote correct movements, not only looking at how many repetitions someone can do in therapy, but also looking at the quality of their movements. Then the second one is looking at the actual repetitions to try to get people to move more. And then the last one was to be able to share the results of my PhD back with the stroke survivors that contribute to my project. So the movement that I was looking at in my project was trunk movement. And you can see in that image that this is a person that had a stroke. We're asking him to to reach forward and grasp a cone. And instead of using only his arm, he's leaning forward with his trunk. And you can see that with the yellow arrows. What happens with those movements is that the more people are using their trunk, the less they use their arms. And what therapists are using at the moment is something called trunk restraint, which is basically strapping a person to a chair to avoid them from moving their trunk. So again, this got me thinking of maybe better ways of doing this instead of having to strap someone to a chair. So what I proposed to do in my project was to use motion tracking cameras. These are cameras that are now commercially available. They come with video game consoles, and you can use them to track how people are moving in space. So they were perfect for looking at how people were moving their trunk and their arms. And the second problem, the problem with the number of repetitions, is that, again, a lot of people go to therapy, but sometimes they don't even get the number of repetitions they need to recover. So what I did is that I had a look into what technology we could use to do this, and I ended up choosing to use robotic devices. And the reason for using robotic devices is that they were originally created to repeat functional tasks. So they're perfect for this type of rehabilitation movements, as long as we adapt the robotic devices to work with people. So that's what I did. And then the third objective I had was related to sharing the results, because a lot of the times as researchers, we do the studies, we do the different experiments, and we publish this in scientific journals, but we never go back and share the results with the people that were involved in the research. So what I did with the Public Scholars Initiative is that they supported me to go back to the research, to the recovery groups where I recruited people, and then I shared the results with them, and I did the same with therapists from a clinic. And I think this is a really important step, not only in these type of projects that are related to rehabilitation, but just in general for any PhD project, to be able to give back to community. And now specifically into what I actually did in the lab, is in the lab I had 2 robotic devices that people could hold on to. They could move their arms, and by moving their arms they were playing a really simple game on a computer screen. And I had a motion tracking camera in front of them so I could look at how much they were using their trunk. And the idea here was to try to reduce that movement to get them to use more of their arm. The task that they were playing was 2 cursors. Each cursor represented one of their hands. So they had to move their hands forward, and by moving their hands forward, they would move the cursors towards a target, and they were instructed to stay there for 1 second. And what happened is that because people are used to using their trunk to get there, we were giving them real-time information about their movements. So at the beginning, if they moved their arms, they would have the 2 cursors empty, but if they started leaning forward using their trunk, we would start filling up the cursors with red ink to indicate that they were doing an unwanted movement, and in the hopes that they would reduce it by seeing this information. And then the other option we had was to provide force feedback to the 2 robotic devices. So if people were leaning forward, they would feel that the 2 robotic devices would become stiffer or harder to move. And again, this was a cue to let them know, try not to use your trunk, lean back, and only use your arms. So the good news is that I completed the studies, and the information actually worked. The information we were providing people to reduce their trunk movements worked, and the results were actually shared. Like in the last couple of months, I went back to the different recovery groups, and I shared this information with all the people that participated in the study and with the therapists, and overall it was a success, I think. So I want to thank all my funding agencies, all our collaborators, and if you have any questions, we're going to have a Q&A session, but also my email is there if you want to send me an email, and thanks a lot for your time.
Thanks, Bulmaro. How can transgender youth, their parents, caregivers, and healthcare providers work together to make healthcare decisions that support trans youth well-being? Our next speaker's interdisciplinary research focuses on improving health outcomes of marginalized populations through the study of healthcare access, ethical decision-making, and shared decision-making processes. Please welcome Beth Clark from Interdisciplinary Studies. Can I do it again? Please welcome Beth Clark from Interdisciplinary Studies.
I'd like to tell you about some amazing youth and families and healthcare providers I've had the pleasure of working with for my dissertation research. These youth are thoughtful, passionate, creative, and insightful, and they face some challenges due to stigma and bias in our society. Their healthcare providers recognize these challenges and also how stigma can impact health. They understand that these youth sometimes need healthcare services that are hard to access. And I think our timing's not working, so, all right. They strive to create inclusive environments where they can understand and meet the needs of youth and families and help them to achieve their life goals. So transgender or trans youth have an experience of gender that is different from the sex that was assigned to them when they were born. They may be a man, a woman, both, or neither. So I'm going to use the word trans today to include all of these genders, but acknowledge that this word does not fit for everyone. Gender health means living in the gender that feels most real or most comfortable and being able to freely express that gender to the world. This is something that many people take for granted, especially those whose gender matches the sex that was assigned to them at birth. Unfortunately, many trans youth experience barriers to expressing their authentic gender. Some trans youth need medical intervention to help align their bodies with their gender. This is often called gender-affirming medical care. One type of this care, hormone therapy, supports the development of secondary sex characteristics that can help someone feel more comfortable in their body and in how they are perceived by others. Research shows us that trans youth who have access to gender-affirming healthcare and family supports are generally doing very well. When these things are not in place, youth can experience challenges related to mental health, substance use, education, housing. But when they are supported, they can thrive as happy, healthy, fully included members of our society. So my research is designed to contribute to the public good through connections with 4 distinct groups: policymakers, healthcare providers, parents, and youth. We currently lack comprehensive evidence-based policy to guide delivery of inclusive gender-affirming health services, and further research is really needed to inform emerging best practices. Healthcare providers connect policy to patients. Understanding the barriers that exist is essential for making care more accessible. This includes exploring ethical challenges that healthcare providers face, such as the allocation of scarce resources and uncertainty about how to best meet the needs of the youth in their care. Parents and caregivers of trans youth play a vital role in supporting health and well-being. It is often parents who are navigating the healthcare system and advocating for their children. Bringing attention to the challenges they face can inform how family-centered, gender-affirming services can be enhanced. So my primary goal is to address the well-being of trans youth through research and knowledge exchange. Youth stories about how they make healthcare decisions and the supports they need are central to this project. It's important to me that youth voices are not only accurately represented through my research, but that I give them direct voice to raise awareness of their experiences. I've interviewed 47 youth, parents, and healthcare providers across British Columbia. The Public Scholars Initiative has enabled me to collaborate with the Provincial Health Services Authority and to travel across the province to rural settings and to urban centers. In the coming months, I will be meeting with participants to share and validate the results of my analyses. Every youth in the study has expressed interest in participating in an arts-based knowledge exchange project, allowing them to learn about the research process, develop new skills, and give direct voice to research results. So how will this work? I will bring the results from my analysis to the youth, and they will let me know if I got it right, if it makes sense, and what I am missing. The youth will be able to select one or more themes as a basis for their knowledge exchange project, deciding who their target audience is and the medium they think fits their skills and the delivery of their messages best. So this could take many forms. It could be writing, prose, poetry, visual art, video, it could be theater. I'll be working with the youth and anyone else they wish to include, policymakers, healthcare providers, parents, trans artist mentors, to envision, create, and share their knowledge exchange project. So in closing, trans youth are amazing, thoughtful, passionate, creative, and insightful. Research engagement with the public can bring together missing pieces necessary to improve our healthcare system and create a world where trans youth are supported to freely express their gender and to thrive as happy, healthy, fully included members of our society. Thank you.
To please have a seat over there. I'll invite the first 4 speakers up here, and as they're coming here, I'll give you a minute or two to turn to the person next to you and come up with one question for one of the speakers. So just take 2 minutes. If you don't know the person, introduce yourself. More seconds. Okay, let's begin. So which group would like to go first? If you have questions that would apply to all 4 speakers, we could start with those, or you could target your questions to individuals. Colin?
Yes, this is kind of a question/observation that I think would apply to everyone, but it was inspired by Laura's presentation. And perhaps because I'm visually impaired myself or blind, I really appreciated how she described her slides as she was going through the presentation. And to me, what that does on a really concrete level is exemplifies some of what it takes to be inclusive in the work we do. And it's the kind of thing that many people wouldn't think about because I imagine most people here are sighted and you can see the slides easily without doing that. But in this particular case, I think it sort of, it showed this level of perceptiveness and inclusiveness that is challenging and very much appreciated on my part. And I think it also reveals that sometimes we don't know exactly what we need to do to be inclusive because not everyone is so obviously in need of, quote, inclusion.
Thank you, Colin. Yeah, so and you might not know, the talks that were done today are typically, I think, 20 seconds a slide, and the slides automatically advance. So there are, I think, 15 slides that you had. And so I started to do that, and I was like, okay, well, I'm going to be describing my slides, and I realized, I have 15 slides. I'm going to be spending more than 15 minutes just describing my slides. So I only got 4 slides, something like that. Yeah, but for that reason that it was important to me, I thought it seems a bit inappropriate not to describe my slides, considering the work that I was doing. But I really appreciate the point you made about we don't know what we don't know sometimes. So, yeah, I'm always glad when someone points out to me what assumptions I've made and how I can be more inclusive.
Other questions? Yes?
My question is sort of about the intersection between Bulmaro and Stephanie's work. So, Bulmaro, you've developed this really neat tool for therapy. It seems like it works. You've run about it and tested it. Stephanie presented that it takes 10 to 20 years for something like this to get into practice. What's next? How do we bridge that? How do we get this into practice without waiting 20 years?
So I guess you have the answer, yeah.
I don't have the answer, but this is interesting because my master's work was actually looking at the adoption of virtual reality for rehabilitation. And being a therapist myself and having learned about different technologies that can be useful, came across so many barriers to its adoption. And it's almost, I mean, as therapists, we want evidence to support the use of the technology, but we have to wait for the research to be done. And by the time the research is done, and there's enough research to say this is unequivocally a great thing to do, there's new technology, and that technology is outdated. So you have to come up with a balance between the level of evidence that you want to have moving forward, the way that you're using it, how you're measuring outcomes at the level of the individual client or patient, and then hopefully some of the other work as knowledge translation researchers are doing can help to speed things up.
Yeah, another question for Stephanie. Would you mind share with me an example of the technology in your research that you have tried to apply your model of connection and to make it happen?
I don't have an example of technology that I've used that approach for, so I decided to pursue my PhD so that I could learn about social network analysis. It's quite complex, as I've discovered, and so to have the support of a committee to help me work through that and apply it will be really valuable. So you'll have to stay tuned for that. But maybe Bulmaro can partner or something.
Yeah. Yeah.
Thank you very much for all your presentations. I'm just wondering if any of you can speak about the idea of access, because it seems to have come up a couple times, and if you've ever had any challenges reaching your intended community or demographic, and if so, how do you go about the idea of maintaining a close communication or liaison with the people that you need to be speaking to?
Yes, so talking about access, one of the biggest challenges in my PhD was actually getting people to come to UBC and try out the technology. And just trying to find people that had a stroke, that are living in the communities, that are in the chronic stage was really hard. So in terms of like what you were asking, what are the kind of things that we have to do to get that access, I ended up going into the recovery groups, into gyms like this all around BC, around Vancouver, to try to get people and show them what are the things that we're doing at UBC. And that's why I actually think that what PSI is doing is amazing, because we can actually get to show people that what we're doing is not something inside of a lab and we're alone and no one has to know what we're doing. Like it's actually something, I couldn't show you more videos because of the time, but like if anyone sees that, like when I was showing that into the recovery groups, they were all like, oh yeah, I really want to participate, that's great. And sometimes the problem with the access was actually just getting people to travel all the way to UBC, getting into a bus and taking 2 hours of their time to get there. Sometimes they're using a wheelchair or they have other difficulties traveling to UBC. So that was one of the problems that I faced with the access.
So in my study, one of the things I did was, before I went back to school, was start working directly with the communities that would be part of my research. So both in paid work and in volunteer work, getting to know the stakeholders and to understand what the research needs were within the community before I decided what I would go ahead and research. So I support community-based participatory action research. It's not my methodology for my dissertation, but I'm trying to take as many pieces of those as I can by just working directly with community. And then I had relationships with healthcare providers. So many providers participated in the study, and then they let other youth and parents they were connected with know. So I actually had no problem at all recruiting for the study. I had more than enough people who were interested. I think it's that ongoing relationship.
Just quickly, so I think because I'm part of the blind community, that helps. And to speak a little bit to the getting there issue, the PSI initiative has helped for me to be able to help people get places, which is very good. And then one of the challenges as well, because I'm looking at belonging, is that if I can find people who already belong to certain places, because if I go to an organization and recruit through them, it might be that someone is already involved in some way in the community. So sometimes it's reaching those people who are particularly on the margins that can be a challenge. So we need to be very creative when trying to reach out to people.
Please join me in thanking the speakers. So if you have any other questions. Okay, well, Susan's not listening. So the same format continues. We're going to have 4 more speakers and then Q&A. Mothers and clinicians face a complicated question when treating postpartum depression. Does the potential therapeutic effect of prescribed antidepressants outweigh the risks of antidepressant exposure to the newborn? Our next speaker's research investigates how different types of maternal antidepressant exposure affect the neurobiology of mothers and the male and female offspring in the adulthood. Please welcome Aarthi Gobinath from Neuroscience.
Thanks, okay. All right, so I will be talking about how my dissertation research in basic neuroscience connects with public health policy specifically aimed at mental health. So we have a problem in basic neuroscience research right now in that there is inequality in how males and females are represented as subjects. In fact, a majority of scientific studies focus exclusively on studying the male brain under the assumption that what we learn in the male brain will be true for females, and we're actually doing a disservice by not including female subjects. And it's not simply a matter of equalizing the number of male and female subjects we're studying. We also need to respect the fact that there are unique female biological events, such as pregnancy and postpartum, that do affect how diseases present, as well as how diseases can be treated, especially when there's such biological changes. And in fact, the brain is susceptible to these changes during pregnancy and postpartum. In fact, during pregnancy, brain volume actually shrinks, and then after a woman gives birth, brain volume slowly returns to its preconception size. And not only are there these big changes in the brain, there are also much more detailed changes that are happening in the brain as well. So it may not be surprising that there's an increased risk for mental health issues at this time. And in fact, it's estimated that approximately 15% of mothers suffer from postpartum depression, and nearly half these mothers are actually experiencing depression for the first time ever in her life. So there may be something unique about the biology behind pregnancy and postpartum that's increasing risk for depression. So what my project in the Public Scholars Initiative focuses on is how can we better understand postpartum depression. And so I'm analyzing the current framework that British Columbia clinicians use to approach postpartum depression, and I want to understand how basic neuroscience research can help fill in the gaps in our understanding of this disease. So what I'm focusing on is in treatment options, and we know that there are some treatment options such as talk therapy that are effective, although they are costly. On the other hand, prescribed antidepressants are much more cost-effective. However, these prescribed antidepressants, such as Prozac, do pose some problems in pregnancy and in postpartum. And these drugs do cross the placenta and remain active. They also can enter the breast milk and then remain active. And in this way, the newborn is directly directly affected by antidepressants. And as of right now, the scientific literature cannot say for sure what are the long-term effects of these newborns being exposed. But neuroscience research has these tools in terms of animal models of disease, and in this way we can start to understand the biological mechanism behind postpartum depression, as well as how different types of antidepressants can work in these models. And we can also understand brain, and we can understand behavior. And now it might seem somewhat counterintuitive trying to model depression, a very subjective mood disorder in humans, in a non-human species like rats. But when we look at the clinical symptoms surrounding depression, there are actually a number of physical changes that happen with depression that are easily quantified. So for instance, changes in sleep or body weight or fatigue can actually be easily modeled in rats. And we also have the advantage of an accelerated timeline when we're studying rat models. So the postpartum period is just 3 weeks in rats, and also the time it takes to age a rat pup to adulthood is just another 8 weeks. So we can start to lay the foundation of understanding what are the long-term effects of maternal depression and its antidepressants. And what we're finding is that in my own dissertation research, as well as in surveying the literature, that there does seem to be something different about the maternal brain that is not as responsive to antidepressants. And in fact, the very few clinical studies that are explicitly studying this suggest that there actually doesn't seem to be any better of effect in using an antidepressant than a placebo. And even more concerning, it seems to be that exposing mothers to antidepressants does have long-term effects on the adult offspring when we look at the preclinical literature. So it is linked to increased anxiety-like behavior in adult male offspring, but not in females. So there also needs to be consideration for studying males and females in this regard. But there does seem to be some hope when we look at other types of antidepressant interventions. So for instance, exercise seems to have some protective effects on maternal mood. But this is an exciting line of future research, but we also do need to understand better how we can increase access to exercise-based interventions in the community. And so what I'll be focusing on is how we can take this information, and then I'm going to put it together in a policy brief so that funding agencies can be more aware of the fact that we don't need to just urge scientists to use males and females, but we also need to take away that there are unique physical events that happen in males and females, such as pregnancy and postpartum, and we need to better understand how these factors factor into mental health issues. So with that, I'm going to conclude by saying that we need to advocate for women's health research by including female research subjects, and that basic neuroscience research can be a useful tool for studying brain disease and mood disorders, and that neuroscience research needs to support equity to promote brain health for everybody. Thank you.
Our next speaker works to improve the quality of hospital care for newborns and children in Rwanda. To do this, he evaluates the effectiveness and implementation of a multifaceted quality improvement intervention. Potential outcomes of his research will help inform practice, policy, and research to improve newborn and child health outcomes. Please welcome Celestine Hategeka from Population and Public Health.
Good afternoon, all. I'm very pleased to have this opportunity to talk to you about my research around evaluating an intervention implemented in Rwanda to improve newborn and child health outcomes. Further, I will discuss how this program is related to advancing health and improving to start, let me give you a quick background of where Rwanda is. Rwanda is a small country in sub-Saharan Africa. So it has a very young population. Despite that, it has very few pediatricians. So how are the children they are doing? So as you can see, there has been substantial progress in terms of reduction of newborn child mortality, but there is still a long way to go. Some of kids are still dying in hospitals because of poor quality of care, or they are taking care of people without specialty care. In response, a program called Interdisciplinary developed in Kenya has been introduced in Rwanda to increase competence of healthcare providers, but also to disseminate evidence-based guidelines to improve quality of care provided to children. Since the introduction of the program, healthcare providers have been trained. So we try to assess the potential impact of the program on the skills and knowledge of those who are trained. As you can see, there has been improvement in skills and knowledge, and about 2/3 of participants achieved competence. So what are some of the reasons people who participate in training were failing? Looking on the baseline, you see their knowledge on images care was very low, but they improved significantly following the training. Then when you try to look on skills, you realize that they did very well, with the overall pass rate of about 80%, but some of the components really accounted for the majority of failure of those healthcare providers. I should highlight it, probably it's due to the mannequins that were used in the training, which is contrary to real practice. We also try to evaluate key factors that could explain differences in terms of performance. So we found that language proficiency and the location of the training were important in terms of how people were performing, as well as the format of materials they were given before the training. So we also try to assess the capacity of hospital to implement the program, looking on the resource available, whereas there was enough resources available to implement the program, but there was adequate triage system, but also reading course of deaf guidelines were also not available. So we assessed the quality of care in terms of process. We realized that there was substantial gaps in terms of the assessment of very sick children, but also in terms of prescribing. The drugs were not appropriately prescribed in those peripheral hospitals. So while these gaps have been identified and then we implemented the program to improve the outcome, there haven't been any evaluation really. So for my research, my PhD as well as my PSI component, I focus on these three objectives. The first one is evaluating the impact of the cost, and then the second one, I look on economic evaluation of the program, given that low-income countries like Rwanda really need to invest scarce resources to the most effective and cost-effective interventions. So that will help to guide the policy decision as well. So specifically as part of a PSI component, the support that I will use it to evaluate the implementation of ITAD. Given the importance of a context and the reality, the intervention are implemented with perfect fidelity, so it's important to evaluate to sort of know the barriers to its successful implementation. So while we identify gaps that can be bridged, so it's important that we make sure that the program is successfully implemented. So when I evaluate the evaluation that I will do along with the Rwanda Pediatric Association, I'll be able to provide evidence to guide further strategy to improve its impact. So I would like to acknowledge my PSI and then my other findings, the Rwanda Pediatric and my mentors. Thank you.
Thank you. Our next speaker is a health literacy researcher and advocate whose current work focuses on trans and gender non-conforming people's experience of cancer and health decision-making. This work is located within the Cancer is Margin project, Canada's first nationally funded research project exploring the intersections of cancer with gender and sexual marginality. To tell its story, please welcome Evan Taylor from Language and Literacy Education.
Presenter view, I guess?
It's on. Oh. It's on, so it should. Let's test it. Yeah, good.
Thank you. Hi folks, I'm Evan Taylor. I'm here to talk to you today about the Cancer's Margins project. So Cancer's Margins is the first, as we said, first nationally funded project in Canada that looks at the intersections of gender marginality, sexual marginality with cancer health and decision making. We're funded by the Canadian Institutes of Health Research and of course the PSI, thank you very much. We are in partnership. There's 5 different universities across Canada that are partnering with this. We have researchers at all those universities, and we're now moving into the knowledge translation portion of our work. So what we're doing is we're talking about our results, and we're doing this through traditional academic avenues such as journal articles and manuscripts, but we've also released a website recently, lgbtcancer.ca, and this is the very first online archive of queer and trans people's experiences and stories of cancer. Of course, research is very important when it can inform how it is that healthcare is designed, so that's a primary purpose of this project. But also to start to investigate how it is that LGBT health research is done. When we start looking at some of the health disparities, we're looking at health disparities in terms of cancer for LGBT people, but when we're looking at LGBT cancer, we're talking about both gender and sexuality, and we're conflating them. So one of the important things about this project is that we're starting to really delineate exactly what are the differences between gender marginality and sexual marginality in terms of people's experiences of cancer care, which is very important. If we're going to start addressing some of those health disparities, we have to importantly connect medical competency with cultural competency. It does us absolutely no good if we know exactly how to treat people culturally, but we have no medical competency, and it does us absolutely no good if we have all the medical competency in the world, but we can't get people in the door to get treatment. So the research methods. We have to this point interviewed over 120 participants and members of their support networks. This particular piece I'm going to talk about today for the next couple of minutes is just the subsection of 10 trans and gender nonconforming folks who are diagnosed with breast and gynecologic cancer. And the study itself is designed around the social study of medicine. In terms of demographics, I'm not going to get into the individual details of every single person, but suffice to say, we have an age range of about 35 years, between 30 and 65, race and ethnicity mapped onto that of the general Canadian population. In terms of gender, identity, and sexuality, people used such a wide variety of words to define themselves. I would say that no single participant used the exact same set of words. All of our participants in this subsection were assigned female at birth, but some had undergone various changes in gender identity, some with medical intervention, some without, and of course all had been diagnosed and treated for breast or gynecologic cancer. So the first finding, I'm going to talk about 4 different major findings. The first finding is that cancer surgeries are experienced as practices of gender-affirming care. So a mastectomy is often performed as part of breast cancer treatment. Our participants were saying to us, not only is this surgery meaningful to me as part of my cancer treatment, the surgery is also meaningful to me in terms of pursuing a different or alternative form of gendered embodiment. So it stood in place not only as a cancer surgery, but also as a gender-affirming care. And this was the same case with hysterectomy. So Lake says to us, this is good news. I wanted a hysterectomy anyway. I'm just going to get this part of trans surgery done first. Works for me. To me, it was all positive. Although I was told there's a possibility of cancer here, that's not what I heard. What I heard was, I get a free hysterectomy. Our second finding is that the organization of breast and gynecologic cancers as women's cancer shapes the experiences of trans and gender nonconforming patients. So there's quite an invisibility that's then structured into how the care is provided. So what happens for folks is they're going to be going into a clinic, and that clinic is not prepared to see someone who looks like them there. So when that happens, we're hearing a lot of our participants say, I felt various different forms of service refusal. I went to get treatment, I couldn't get treatment. So John tells us a story, and he said, they told me that I had to sit in the hall, but my girlfriend could sit in the waiting room. I wish I could have said, no, I am a patient here. I also lived the first 25 years of my life as a woman. I would like to sit in the waiting room, but I didn't want to make a scene at the time. Our third finding is that there's significant overlaps in the bodies of knowledge that are informing how people are making decisions. So when people are making decisions about their gender care, they are absolutely considering their cancer risk profile in that. When people are making decisions about their cancer care, they are considering their gendered embodiment and their gendered identity and expression in their considerations for cancer decision making. So Blake told us, I've totally considered taking hormones, but my partner's approach is, prove to me that taking testosterone will not give you cancer. It's very hard, the jury's out on that, so I haven't done it. And the final finding is that trans and gender non-conforming people's experiences of breast and gynecologic care are absolutely intricately linked with their experiences of intersectionality. So where they are on any sort of demographic chart of gender, race, talking about class, talking about ability, all of these all of these different intersections are really shaping how people are experiencing care. And they're not able to say to us, it was because of this thing. So what's happening is when these experiences are not compartmentalized, they don't know, am I experiencing this because of my gender identity, because of my sexuality, because of my race? And they're not sure. So what they're doing is they're taking steps to mitigate and basically erase some of these complexities. So Dario said, I think it's layers of invisibility. It felt like we were these radical lesbians of color. I don't even know if that's how they read us or not, and that really wasn't where we were coming from, but that's how we felt like we were being treated. And after that, I didn't let my partner come to my appointments anymore. So in conclusion, a big, huge piece that's coming out of this is really noticing that trans and gender nonconforming people are really highly motivated to seek knowledge, get information about both cancer care and gender affirming care. But very importantly, cisgender models of care are both medically and ethically insignificant. They are not sufficient enough to actually inform how it is that we're designing care for gender diverse populations. So that requires a shift away from that binary organization and starting to understand sex, gender, sexuality as more of an intersectional approach. And I'll leave the final word to John. And John says, really what we're talking about here, we are talking about patient care in a clinic that doesn't need to be gendered. Thank you very much.
Thanks, Evan. What role can schools play in providing student mental health support? Our final speaker collaborates with high schools in British Columbia to adapt, implement, and evaluate mental health literacy interventions with an aim to build capacity for promoting student well-being, reducing stigma, and effectively supporting students who experience mental health difficulties. Please welcome Jamie Senchuk from School Psychology. I'll do it again.
Just wait. Right here. Ready? You can do it now.
Okay, I'll do it now.
But I don't see it.
Please
here.
welcome Jamie Senchuk from School Psychology.
Thank you. In my research, I am interested in the role that our schools and education systems play in promoting the positive mental health of students and supporting students who experience mental health problems and mental illness. So why incorporate mental health education and support into schools? For one, mental health problems are common. As many as 1 in 3 Canadians will experience a significant mental health problem in their lifetime, and the majority of those mental health problems will develop during school age. In fact, 1 in 5 students in BC classrooms are currently experiencing significant mental health problems. And unfortunately, of those students who are in need of services, as little as 30% get the supports that they need. Additionally, incorporating mental health supports into schools allows for us to meet students where they are at, because most are already spending a significant amount of time in school, up to 30 hours per week. Beyond providing additional formal mental health services in schools, we are able to reach the most students when we take a whole school, collaborative approach to supporting mental health needs of students. When this happens, we start to break down the silos, and mental health is not just the responsibility of the school counselor or community mental health provider, but teachers, special education assistants, administrators, and students begin to take on a role. In whole school approaches to supporting student mental health needs, the concept of mental health literacy becomes foundational. This is the idea that there are certain competencies and knowledge that we all should have surrounding mental health and mental illness. Specifically, mental health literacy includes the knowledge, skills, and attitudes that allow us to recognize, manage, and prevent mental health problems. When mental health literacy is developed in school settings, educators are able to understand and implement student mental health promotion strategies. There's also enhanced capacity to identify students in need of mental health services and help them access appropriate community supports. Additionally, mental health literacy promotes positive attitudes towards mental health and reduces stigma to create a more inclusive and supportive environment at school.
I initially became interested in educator mental health literacy during my master's research, where I interviewed youth with anxiety and depression about their experience of school-based supports. Out of all the services and supports the youth discussed, they spoke in the most depth about the significant impact that teachers have on their experience. The youth reported that when educators are knowledgeable about mental health, willing to accommodate a student's individual needs, and show that they care, this goes a long way in supporting students who are dealing with a mental illness. Educators are increasingly being recognized as frontline responders in supporting student mental health. Educators themselves acknowledge that they are required to respond to student mental health needs in their daily practice, but they often feel ill-equipped to do so due to lack of relevant training or uncertainty about their role. In my research, I seek to address this gap. I engage with high school educators in skill-building mental health literacy workshops with the goal of increasing their knowledge and competence in supporting student mental health needs. Following the workshop, we collaborate in a school-based action research team where we plan, implement, and evaluate mental health literacy practices. This includes programs and policies that impact the broader school community. Through student engagement and the lived experience of the educators, we are able to tailor our plans to the specific needs of the school community. This research will not only have a direct impact on the high school communities I collaborate with, but will contribute to the public good more broadly by helping to identify the actions required for educators to feel knowledgeable, supported, and confident when incorporating mental health literacy into their practice. By increasing educator mental health literacy, we increase our capacity for whole school, collaborative approaches to supporting the mental health needs of students. Thank you.
So let's invite the other three speakers here. And being mindful of time, let's skip the small discussion, group discussion, and continue with the questions right away. Yes.
Sorry, I have some questions. First of all, for Jamie, can I have two questions?
Okay.
How would you engage and motivate educators given their existing workload? Because some of the teachers will say, I'm already burned out, and as soon as students receive what should I, what was the point that I should take the extra step and to take care of their mental well-being? And my second question to you is, what's your design model? What's the next step to follow up once the mental health problem in the student is identified?
So I'll answer your first question. I need you to clarify a little bit on the second question. And that definitely is a consideration for educators, this idea that this is maybe something extra that they feel they need to take on. Generally, in the educators I've worked with, they find that this is something that they're faced with, and that they have to respond to, and so they're seeking out that they need more knowledge, they need more resources to be able to do this. But I think that is what, in working with teachers, that is one of the things of finding that balance, is how are we able to incorporate this into a way in schools where it feels manageable, it feels like it's a part of what their workload is already, and not something extra on top of what they already need to do. And I'm sorry, I didn't quite understand your second question.
So what would you recommend the educator to do once the mental health problem in the student is identified?
What would you recommend? Okay, so they're noticing a change in the student. So what they may want to do is, if they have a relationship with that student and they feel they can start a conversation and say, I've noticed some of these changes, and start that conversation based on their relationship. If they don't feel comfortable, who is someone in the school who the student has a good relationship with? It could be another teacher, it could be the school counselor, it could be a coach. Who is someone where that student has a trusting relationship, where they can start that conversation and say, I've noticed these changes, I'm concerned, and just start that conversation and see where it takes them.
I was just wondering, maybe not a solution, but some strategies that might be come to mind about ways to foster gender and sex equity in health research, or maybe the two of you and
Well, first of all, I think the number one thing we can start to do for my perspective in terms of my work is how we do electronic medical records. Right now, we don't keep track of, in any sort of meaningful way, about people's gender, identity, expression. And so instead what you get is you get a solid M or an F, and that's it, as if that tells you something about the person's body. And I think it's important that we start looking at electronic medical records that take basically an organ inventory of the body. Instead of saying this person's a woman, we say this person has a cervix, this person has breasts, this person, or maybe they have one breast, maybe they have, So keeping electronic medical records that actually accurately represent the health and bodies of the people we're trying to serve, I think is the first step I would say from my perspective.
Yeah, and I would agree with that. In terms of neuroscience research, I would say that we're starting to begin to realize that even things like genetic differences and also history of how someone has been taking antidepressants, when did their first ever episode of depression happen? Was it during pregnancy? Was it well before? Is it something they struggled with for their entire life? All of these things are starting to matter, and so this whole idea of precision medicine, that we want to start tailoring how an individual's best medical treatment can actually fit what their whole life history has been. So yeah, we need to actually start taking like sex and gender and just really like a person's life history, and I think electronic records are a great way of doing that.
My question is for Sebastian. I'm asking this question because I understand that there has been in the past an approach where when centers designs and interventions outside Africa and bring them to our country, and for ways in that case they can actually apply it in different countries, assuming Africa to be the same. So I think based on what you said that the tool was developed in Kenya, I just wanted to understand how has the tool accommodated the differences in the culture and elements, and how have you been able to contextualize into one explanation?
Did you hear about?
Not very.
So the program was initiated in Kenya. How was it accommodated in different cultures, in the neighboring countries and in different places? And did you face any problems in relation to that?
Oh, awesome. Thank you. One of the issues of usually, I recently the Interdisciplinary Studies developed in Kenya, which has a lot of commonality with wildlife, the disease profile, as well as the economy itself. So most of the intervention usually used to be imported, and they're there and they're not really aligned with the local context. So Interdisciplinary, as I said, when it was developed, it was one of the approach to really develop intervention which are local appropriate. So I was developed in Kenya, and then Kenya working with the Rwandan Pediatric Association, the Kenyan Pediatric Association played an important role actually in helping us to integrate the program. Initially we had their instructors coming over to support us, initially training us. So I was fortunate to be part of the program when I was studying. I then became the first instructor. I worked on the program. So what have been happening over the time when of relevance here, during the system of education in Rwanda changed. It used to be in French. I did my medical education like half in French, then back in 2008 it shifted to English. So when they were coming, so most of they speak French English. So some of the people who were being trained, they were also having issues following the coursework in English, as they would just translate. They were just shifting to English, but they were not really used to sort of follow coursework in English. And also healthcare providers were working in the hospitals who were old, never even got an opportunity to learn English. So training them, working with, sort of trying to integrate the program in Rwanda was very difficult initially. So then we had to realize that, and then we we worked on translating to sort of have another document in French. So people who speak French could also be accommodated. But also the people then who the training would be either in French or English or combined, but there are also some people who would even prefer to run in the local language. So you start teaching them the local language. There are some of really medical graduates out there who don't even speak the local language. So all those has been issues, and then the program has been adapted to meet all the programs. I think since its introduction, there have been a lot of change.
We are running out of time, so join me in thanking the last four speakers. So before we call it a day, I'll pass it on to Susan to say the final words of the day. And if you had doubts about, I'm missing the sun and everything, it's already gone. So that's, thunderstorm is coming, so that's the silver lining. Okay, well, I'll pass it on to Susan. Thank you very much for your time and being here and engaging in the last of the PhD to go public in this semester. Thank you very much.
As usual, this has just been a fabulous afternoon. I'm so impressed with the commitment you folks all have to these really important topics, the scholarship that you bring to this, and it gives me great hope for the future. It really does. I thought, I tend to look for linkages, and yes, you work with together, so there's some obvious linkages, but to me, it was about improving well-being, improving health, improving a sense of belonging, improving community, improving our interactions with one another. And much of what you talked about was the old-fashioned term of knowledge translation, knowledge mobilization, and how that's really changing. I mean, I find that a fascinating field. And it's no longer the case of us sitting in our laboratories and finding something that's going to be useful, I'm sure, for you, and then passing it out. But you're not only investigating how to do that properly, but also you're using those tools of knowledge translation and knowledge co-creation that are clearly going to be useful in the long run. So healing, a variety of ways of healing mental health, healing isolation, healing from disability, healing from illness and injury, and all the ways that that the people that are experiencing these can help you find solutions. So I have to say I was a little bit, I drew a little bit of a parallel with the stone soup analogy in that maybe this is a bit of a long shot, but you folks, you researchers, go into the community and you have a magic stone and a cauldron, and those are your skills and your knowledge, and everyone contributes to the final result, and it's a beautiful product. So I don't know if that's too much. But I did sense that, I see a big difference in the way, I've said this, but the way research is both done and the ways research is implemented. And you guys are, I think, at the forefront of that transition in scholarship. So wonderful. Thank you so much for a fascinating event.